All right. So the other thing I wanted to review, just kind of getting ahead of the anatomy and physiology stuff, is some of the cardiovascular system, just the different structures and kind of the flow of blood. We jumped right into it with CHF, and when the blood's not moving forward, it starts backing up. But just really getting all those structures and the terminology back out there for the proper sequence of everything, we wanted to kind of start there. All right. So structure-wise, we have superior vena cava and the inferior vena cava, bringing oxygenated or deoxygenated blood to the heart. Good. It's deoxygenated. That's all the blood in the veins that's coming back to the heart, right? So the superior vena cava is pretty much everything here up, right? Upper body is going to be coming into the heart via the superior vena cava. So off of the branches of that becomes the subclavian veins and the brachial veins out to your arms and everything. So those all kind of merge together into that superior vena cava up top. Inferior vena cava obviously then goes down, your renal veins, then the femoral veins and everything down through your legs. So lower half of your body all funnels in there. And those go into what structure? Good. Right atrium. Good. Right atrium goes into the ventricle. What is that valve called?
Tricuspid.
Tricuspid, good. All right, tricuspid valve. Any guess how many flaps are on that valve?
Three.
Three, right? Tricuspid, right? 3 flaps on that little valve. Generically, I'll call it what type of valve? You know? I'll call it a AV valve, which is a atrioventricular valve, a valve between the atria and the ventricles. Right? So that's a generic one. That AV valve is not specific to the right side. It's just specific to the fact that it's a valve between the atria and the ventricles. Right? So tricuspid on that side, right ventricle contracts and squeezes blood out. What valve? Yeah, pulmonic valve. Pulmonic valve because then that blood goes to the pulmonary arteries, right? Pulmonary vasculature. Another general name for that type of valve is a semilunar valve. Pulmonic is a semilunar valve. Any guess what shape it is? Yeah, half moon shaped, right? That's just the shape of that valve. That's where they get it. Sometimes they make it real obvious for us. Other times they don't. And so that goes out your pulmonary valve to your pulmonary arteries, right? So then that goes to each of your lungs, right? Branches down smaller and smaller and smaller. And pulmonary arteries, as arteries branch smaller and smaller and smaller, what eventually do they become? Good. We got our pulmonary capillaries, which from yesterday, what structure do those pulmonary capillaries run up against?
Alveoli.
Yeah, those alveoli in the lungs, right? That's that gas exchange part, right? And then the pulmonary capillaries branch larger and larger and larger, and they become pulmonary, what? If it's arteries going that way, yeah, we got pulmonary veins bringing that blood back to the heart. Right? So pulmonary arteries, branch down, branch down, branch down, capillaries, gas exchange, and then they become bigger and bigger and bigger blood vessels, but they're veins on that side coming back. So the same thing, artery that way, get the vein coming that way. And those all dump into left atrium. Left atrium down to the left ventricle through what valve? Mitral valve, or the, what's the other name for it? Bicuspid valve. Bicuspid valve. That valve is also what type of valve? Good. It's one of those atrioventricular valves, just a valve between the atrium ventricles and that side. That's what I'm saying. That's a generic term, right? It just means it's one of those valves between the atria and the ventricle, right? If you have a hard time trying to remember which one is which, some people will say the mighty mitral valve, right? Which side of the heart is stronger?
Left side.
Yeah, that left side is stronger, right? So that mitral valve is on the left-hand side, mighty mitral valve. Bicuspid valve just means it has 2 flaps compared to the 3 flaps on the right side. Another way to think about where that miter or mitral word comes from is like a miter saw, right? It's the shape of the saw blade teeth. Or if you think about that old school really tall Pope hat, right? You know what I'm talking about? Like that Pope hat, right? That hat is called a miter, right? It's the same shape of a miter saw teeth blade. It's the same shape of the flaps of that mitral valve. All right, left ventricle contracts and goes out, what valve? Pulmonic went to the pulmonary system. Where's this valve going to? Aortic valve. Good. Aortic valve is also a semilunar valve. Again, same type of shape. And then that obviously goes out the aorta to the upper body. So again, it's one of those ones that it helps, really helps if you just kind of memorize. If you could figure out just mapping a red blood cell through it, could you hit and name all the structures along the way? So it comes into the right atrium, through the tricuspid valve to the right ventricle, out the right ventricle through the pulmonic valve to pulmonary arteries, pulmonary capillaries, gas exchange, pulmonary veins, left atrium through the left, the mitral valve to the left ventricle, out the aortic valve, out to the body to deliver that oxygen. Right? So being able to name and hit all those structures, because then when we start talking more CHF and more cardiology and things like that, you start remembering, okay, if the left ventricle is not pumping properly that way, it's going to back up and back up and back up, and that's our CHF pulmonary edema. Right? If the right side isn't working properly, pumping it forward, it's going to back up, and then it's going to back up. So what signs would we see of right-sided heart failure? JVD, right? And gravity-dependent pedal edema, right? If they're upright, pedal edema, right? They'll have that swelling in their feet and ankles. If they're bedridden, they'll get sacral edema, right? So wherever the lowest point is, gravity will take it there. So it's good. It helps with understanding like tension pneumothorax or cardiac tamponade, a lot of those things. It's blocking the heart, so we're going to see the body effects. Left-sided heart failure, CHF, heart attacks, you know, it's going to back up into the lungs and cause that pulmonary edema. So by really getting it good with what happens going properly forward, then it helps with being able to just map it backwards and see that's where I'll see the signs and symptoms. All right. All right, so that's the kind of internal structures of it. The part that's not shown on here becomes the vasculature around it. Right? It's like the coronary arteries, like we were talking about yesterday with the heart attack and getting blockages. You have to think about it as the fact that the heart as muscle and the heart as tissue needs its own blood supply. Right? So the heart muscle, right? All that muscle tissue, it's not picking up oxygen from the blood by the blood that's moving through the inside of it. Right? We have those blood vessels, the coronary arteries that are circling back and perfusing the heart tissue itself. The source of those is pretty much as soon as that left ventricle contracts and squeezes that oxygenated blood into the aorta, there's an immediate little outlet that becomes the coronary arteries that goes back and perfuses the heart tissue itself. So the heart's going to perfuse itself before the rest of that blood continues throughout the body. There's an immediate little branch out, and that becomes the coronary arteries that get blocked for MIs, heart attacks. Right? And then just because there's coronary arteries, there's obviously coronary veins that then dump that blood back into the heart to get reoxygenated and everything back in the lungs. So those blood vessels come around. Right? And pretty much because the exit point for that aorta is kind of on the back side-ish of that left ventricle, and then those blood vessels kind of wrap around the back of it and come around the front of it. So ultimately you have your left coronary arteries and your right coronary arteries. Later on we'll venture further into circumflex arteries and everything else kind of continuing. But thinking from yesterday, we said depending on where that plaque buildup and that clot starts to form, becomes a kind of deciding factor with how much of that heart is actually impacted. So if that plaque builds up and blocks blood flow at that point, then it's just any tissue that that blood vessel is responsible for perfusing is now getting cut off from the oxygen supply. Right? So the higher up that is, the more heart tissue is getting restricted from oxygen. Right? More high up, even further. Right? And we said more than likely it's going to be on that left-hand side. Why? Because it's bigger, right? It's going to require more tissue, or more oxygen, so it's going to be more sensitive to drops in blood vessels, and there's just more tissue, so there's just statistically more geography for things to go wrong. Right? You can have right-sided heart attacks for sure, posterior one, all over the place, right? Typically, it's going to be on that left-hand side. If it's really high up that left coronary artery, that's where sometimes you'll hear them say it was a widowmaker MI, right? Because that blockage is blocking perfusion of the entire left ventricle, right? And the left ventricle pumping is the one responsible for giving us a palpable pulse, right? So if we cut off blood flow to the entire left ventricle, really quickly they're going to die, just because that left ventricle is not going to be doing anything more than a couple minutes, right? So when we talk about brain and heart, right? Brain, or irreversible brain death with lack of oxygen for 10 minutes, right? Heart is marginally longer than that, right? It's just extremely sensitive to drop in blood flow before that tissue starts dying, right? So if you cut off blood flow way high up, and we're not really close to that cath lab for them to get in there and open that back up, they're gonna die, for sure. Right? If it's much further down, and this spot starts dying, but the rest of that left ventricle, as crappy as it is, but it can still kind of pump a little bit, then that's still better, right? They'll have a little bit more time, right? That's why they'll go in there and they'll do that angiogram, and they'll insert the dye and see how it kind of moves through those coronary arteries, just to figure out, oh, there's the blockage, and here's how much tissue is being cut off from that blood supply, right? So that's why they go in there and they inject that dye just to kind of see it light up those arteries, so we can see where the blockage is, and they can decide how bad it is, what they need to do about it from there. All right. All right. So we have the internal structures, we have the blood vessels. What else do we have in the heart and its functioning? There you go, the electricity stuff. Good. That's more or less what the electrical structure looks like. We have way up high, what's the top one called? SA node, right? Or sinoatrial node. Right? That's where we get the sinus rhythm from, sinoatrial node. Right? So it's what all of us hopefully are firing based off of. Right? So it's considered the primary pacemaker of the heart. Right? That's what all of us are beating off of. The natural rhythm, or rate rather, that it wants to fire at, any guesses? How many times a minute it would like to fire? Yeah. Yeah. Ultimately, what becomes the normal range for us? Where we say beyond 100, we call it tachycardia. Below 60, we call it bradycardia. Good. So that SA node just wants naturally to fire in that range. That's why we're all generally in that range, right? Statistically, average adult, heart rate is 70, right? But 60 to 100 is the range. Can it fire faster? Yes. Can it fire slower? Yes. Yes. Ultimately becomes, is it causing a problem for the patient, right? If you're like doping era Lance Armstrong, and you have a resting heart rate of 30, and he's sitting on the couch just chilling watching TV, resting heart rate of 30, it's completely fine, right? If my heart rate's 30, I'm probably unresponsive on the ground, call 911, right? So it's person dependent, right? It's one of the ones that we start talking about a lot as we get into this stuff is treat your patient, not the monitor, right? Don't just freak out based on the number that we see. How is that number doing for this patient, right? Maybe it's causing a problem, maybe it's not, right? Once it gets fast, again, 110, nobody's freaking out, right? 150, I don't know, did you just go for a jog, right? Working out? Maybe, maybe not, right? And figure out what's going on with your patient. Why is their heart rate doing what it's doing?
At the same time, could you reverse that? All the vitals are coming back fine, but your patient's not presenting well?
Potentially, yeah. Then you really start digging through, and that's where you kind of play detective and say, the numbers look good, my patient looks like crap. What's going on with them, right? So 60 to 100, sinus rhythm, right? 60 to 100 is sinus. Faster than 100, sinus tachy. Less than 60, sinus brady. AV node, right? It's right there in the middle, or the whole AV junction. It's composed of the AV node and another little bundle of tissue right underneath it. But the AV node or the AV junction, either one's fine. It can also work, right? Because any cell in the heart can trigger its own electrical impulse. Right? Any cell throughout the entire heart can do that. Anybody know what that principle is called?
Repolarity or something?
No. One is automaticity. That means if that cell right there just gets pissed off enough, it can just do its own thing and start firing. It doesn't need to wait from the electrical signal from the SA node or anything like that. Just any cell throughout the heart can start firing on its own. Yeah. So things like VFib, right? All the cells all over the ventricles are all firing, right? A lot of things are going wrong with it. Now, any cell in the heart can do that. Just most of the ones that want to are located right up there in the SA node, and they win, right? Whatever wants to fire the fastest will take over, right? So SA node wants to fire in the 60 to 100 range. That's the fastest of any of the cells naturally, so it's going to win. But if that spot down there says, you know what, screw you, I want to fire 200 times a minute, I'm going to do it and it's going to win. And then we'll be in ventricular tachycardia, right? Because we have a ventricular originating rhythm that's going fastest, it's going to win. So the AV node, if it decided, you know what, I'm going to fire, right? Maybe the SA node's failing. Maybe there's some sort of weird structural damage to the SA node and it wasn't working properly. As a backup system, that AV node can kick on and it can be responsible for driving our rhythm. It wants to fire in a range of 40 to 60. Can it fire faster? Yep. Can it fire slower? Yep. Right? But all things considered, it wants to fire that range. So even all of us sitting here right now, the AV node would like to be firing 40 to 60 times a minute. But the SA node wants to fire 60 to 100 times, so it wins. So we're all sitting here with sinus rhythms, right? If some random spot down in the ventricles was firing, so maybe the SA node failed completely, structural damage, MI, something like that, and the AV node, it also failed, it went away, then as a worst case kind of backup system, the ventricles naturally would like to fire in a rate of 20 to 40, right? So faster, faster. The higher up you go, the faster it naturally wants to. Can the ventricles fire faster than 40? Yes. Yes. Can they fire slower than 20? Not much more, but yes, they could, right?
So like when the SA node and the AV node stop working, is that when like your first and secondary heart blocks come into play?
The heart blocks is specifically there's an issue in there. Something's going on with the ability of that electricity to transmit through that AV node. Those are your heart block rhythms. Yeah, it's the issue is localized right there. Yep.
So when you hear pulseless electrical activity, is that the 20 to 40?
No, so in terms of rhythm identification, PEA, pulseless electrical activity, is any rhythm on the monitor other than VFib or VTAC that doesn't have a pulse. So you could hook them up onto the monitor and it looks like a completely normal, great looking sinus rhythm, and you palpate the pulse and there's no pulse, they're dead. But on the monitor, everything looks great. Yeah. So that's what they just lump anything else, any other rhythm other than VFib and VTAC. They'll say, hey, the rhythm's there, but there's no pulse, pulseless electrical activity. VFib and VTAC, they peel off as their own special thing because we'll shock those. Right? PEA, we won't shock because it could look like a completely great sinus rhythm on the monitor. Electrically, it looks fine. Just for whatever reason, mechanically, it's not working. But if the electricity is not the problem, we're not going to try to fix it with more electricity. Right? VFib and VTAC, the electricity is the problem. We're going to try to fix that with electricity. Yeah?
So PEAs, are they pretty much dead? There's nothing we can
They're for sure dead. Well, it depends on the cause in terms of reversibility. So when we get into ACLS, we end up having, on the cardiac arrest one, we'll call them H's and T's, just reversible causes of why they might be in cardiac arrest. So PEA is the least common out of all of them. But you can think about it if it was trauma in origin and say they just bled out entirely or significantly enough. There's no circulating blood volume or very minimally circulating blood volume. But the heart structurally is fine, right? The heart's trying to just keep doing its thing, right? But if there's no blood in the system, will we ever be able to feel a pulse? No, right? So that could be one cause of PEA, right? Would be trauma, hypovolemia, right? Electrically, the heart's trying to do its thing. There's just no fluid in the system, so we're not able to actually feel a pulse, right? So theoretically, with some of those causes of PEA, if you actually cracked the chest open and took a look at it, you may see the heart in there trying to do its thing. There's just no fluid in the pipes, so we're never going to be able to actually generate a blood pressure and actually feel a palpable pulse. So the PEA ones really starts to become what's going on with them. Is it a weird electrolyte thing? Is it hypovolemia, hemorrhaging? Is it cardiac tamponade, where just something's blocking the heart from working properly, but electrically it looks like it should be? Right? It's a weird one to try to figure out what's actually going on with them. Right? Yeah. Cool. Right. All right. So electrically, what happens, we say if the SA, if all things are good, right, everything's working properly for the person, and the SA node fires, that electricity starts moving through the heart, right? And the only reason why we can see anything hooking the patient up to the monitor is because the electricity is moving, right? And that's why we put those electrode stickers all over the place, is because depending on which ones there are, we're looking at just how that electricity is actually moving through the heart. And whether it's moving towards or away, certain ones of those stickies will make that bump go up or down, that squiggly line go up or down. So if everything is good and functioning properly, and the SA node fires, it starts traveling down what they call the internodal pathways between the nodes, the SA node and the AV node, and it just starts firing all the cells nearby. Right? So the way it works, if we took all of them and went 2-dimensional instead of 3-dimensional, right? If this cell fires, depolarizes, electricity goes, it triggers that cell to then fire, which triggers that cell to then fire, which triggers that cell to then fire. Right? So that's if we just put all the cells in the heart in a line. Right? If we added some extra layers to it and said that cell fires first, it's going to trigger the cells that are touching it to fire. So that cell and that cell will then fire. Those are going to trigger the other ones to fire, so then that one fires, that one fires, that one fires, which then triggers that one, right? It all just keeps going, right? So everything triggers the next cell in contact with it. So then you start stacking that out 3-dimensionally, and electricity starts traveling throughout the tissue, right? Just triggering cell by cell by cell by cell to it. So when that SA node fires, it triggers those cells, but it also triggers those cells and those cells and those cells, and it just transmits. So as that electricity travels through the atria, right, that top part, as that electricity travels through the atria, you get your P wave. I'll try to color coordinate stuff as we go. So that P wave is the electricity traveling through the atria. We'll see it, or we'll say it's atrial depolarization. Right? Depolarization is just electrically it's firing, right? So the atria depolarize, the atria fire, right? That electricity is moving through the atria. It generates that P wave, that little bump. It should be upright and nice and rounded looking. Then that electricity gets held up in the AV node for a very split-second amount of time, and it causes that. I should do a different color. Do blue. Right. So the AV node just holds onto that electricity, allows it to move very, very slowly. It results in a little teeny line, flat line. It's because now it's not allowing that electricity to move. So if the electricity doesn't move, it doesn't generate a squiggly line. Right? Then, very, very quickly, electricity will travel down through the ventricles, and then it'll start working its way back up. Right? And cause all those ventricles to fire. And that's your big spike, which we said was what? Right. QRS complex. Right? So if that P wave is the atria depolarizing, what is that QRS complex? Ventricular depolarization. So that's the ventricles firing, which generally means the ventricles contracting, which means palpating a heartbeat, right? So that is what we're feeling when we're palpating a heartbeat. We're feeling the ventricles contract and kick out that blood flow. specifically the left ventricle actually kicking the blood flow out systemically that we can actually feel throughout the body. And then if the cells fire, we want them to fire again, which means they have to recharge, right? So as soon as the cell's done firing or depolarizing, then it's going to start recharging or repolarizing. And that repolarization just follows behind it, right? So those first cells that fire then are the first cells that start recharging. And that's an electrical process. And so the T wave then becomes repolarization. Right? The heart's recharging, so it can fire again. Recharge, fire again. Recharge, fire again.
So typically another flat line after the QRS complex?
Yeah, sometimes. What do we call that? Yeah, that ST segment, right?